All right, so this morning we were doing airway. Um, so this is kind of one of the first, not that you actually get to do the skills yet, but you will in obviously hopefully near future. Um, One of the first skills that you guys are going to learn in an ALS kind of way that is a little more in depth than IVs. Because IVs, it's just a lot of practice. You Once that muscle memory's in, you're good. When you learn how to intubate, it's going to be a lot of kind of personal feel to like what you prefer, because there's different blades that you can use. There's like some sort of different techniques. And we have different ways that we can actually access the airway that some people will do versus other people, which isn't necessarily wrong or incorrect, but it's personal preference. But airway, obviously, as the A, is super important. The state loves to ask questions about the anatomy of the airway. So the number one thing that you need to know is that the upper airway and the lower airway are separated by the glottis, okay? The epiglottis sits right on top of the glottis and does a really good job of protecting your airway, okay? You can see it right here. It's this weird little funky flap of skin, right? Fun anatomical quirk that we have. So you see how the epiglottis is kind of this like weird squiggly shaped protrusion in the airway. The uvula, the little punching bag at the back of your throat, is also similarly shaped. When you swallow, your uvula swings up and keeps food and stuff from entering into your nasopharynx, while the epiglottis goes down and protects your airway from food going in there. So it's kind of like a double seal valve that's kind of set up right there. The vallecula, if you kind of look right here, is this kind of tiny little cavern right behind the end of your tongue. You are going to need to know what the vallecula is, because this is your kind of your target when you guys start to do intubation. Okay, when you're using the Mac blade, the blade goes right here into the vallecula. The difference between using the Mac and the Miller is the Mac goes in the vallecula and lifts the tongue, and by doing so also lifts the epiglottis. The Miller actually goes on top of the epiglottis and lifts the epiglottis itself. Personally, I prefer the Miller, and I definitely started some noise on Facebook about a year ago or so saying that the Miller was better than the Mac, and all the dinosaurs of EMS came out no, the Mac is better. And I'm like, yeah, but what about that floppy epiglottis? Also, one of the best things you'll ever see in a paramedic textbook is the literal phrase floppy epiglottis. When you have a patient who has a difficult airway or is a little on the larger side, obese or whatnot, the Miller is better for getting a better view, because there's nothing that says that you can't use the Miller like a Mac. Okay, so you can put the Miller in the vallecula and lift the airway, but if you need to get down and get that epiglottis actually physically lifted, you have a little more length with a Miller blade than you do a Mac blade to actually achieve that. Your airway is rigid due to cartilage rings. The thyroid cartilage is up top, is the highest part of the larynx, and the cricoid cartilage is the lowest. Okay, the very first complete ring is the cricoid cartilage. Okay, so basically all the cartilage that's above the cricoid are U-shaped. The cricoid is O-shaped. If that makes sense. The opening for the cartilage is posterior, so that if you swallow something, it actually can push into the airway a little bit going in this direction, so that a large food bolus can pass without getting stuck and blocking your airway. but the cricoid cartilage is your first complete ring, okay? Again, they love those anatomy questions. When someone is intubating, what we also say, oh, give me some cricoid pressure. So person will push on the airway. Hold on, let me stop the share for half a second. I like to do this, and it's not really as effective. If you look at your airway, right? If you move it, it moves back and forth. Kind of creepy, right? So if you have someone applying cricoid pressure, that airway floats to a certain extent. So if you push down, it will, one, improve your view, and two, will kind of push off the epiglottis, so you're less likely to end up in the epiglottis, and you won't necessarily have vomitus come up, which is always really fun, because there's nothing quite as exciting as going in for an airway and all of a sudden be like, oh, vomit. 10 out of 10 does not recommend. All right, so that's my little, your airway is ridiculously mobile, okay? So just knowing that, and knowing, when someone actually has that blade in there, that you can see it. And if you're holding cricoid pressure, and someone does pass the tube, you'll feel it. It's kind of creepy, but at the same time, it's a good, it's like a nice confirmation that, hey, you're in the right spot. Come on. There we go. One of my favorite bones of the body is the hyoid bone. It is not connected to any other bone in the body. It is the only bone in the body that is not connected to any other bone in the body. If anyone's into the true crime stuff, this bone is most commonly fractured during strangulation. It's a very small, very delicate bone, but it pretty much provides the support system for the airway to do that floating thing. Okay, so it's the suspension system for your airway. All of the muscles kind of tie in there. All the cricoid cartilage kind of is all down there. And this is a nationally registered thing. We do not have this available for us in New York City, but if you have to do a surgical airway, the cricothyroid membrane is where we do that. That is right here. So if you, hold on, let's stop sharing again. If you feel your neck, there's like a protrusion, a pretty significant protrusion, and then there's like a indent, sort of like right here. That's your cricoid. Yeah, everyone palpate yourself. That's your cricothyroid membrane. So if you had to do an emergency airway when you have that use a 14 gauge, or if you're in other locations in the world where they actually let you do a surgical airway, it's right here. Surgical airways are kind of cool when we don't really go too much in depth, but you have to cut them in a specific way, because the way that the tension lines of your skin is, or are, if you go in one direction, the skin will just continue to kind of just flay right open. So you do it opposite directions in order to keep the skin from just ripping open, which is creepy. Wait, hold on, let's see what we have in the chat going on. Yes, thank you. 12 pounds of pressure for your hyoid. Not much. New York City police officers have 12 pounds of pressure on their the trigger of their pistols, which is why they often miss, because it's a lot of pressure to have to pull. It kind of sways your aim. Side note. Anyhow, okay, back to here. Another really kind of important thing that you need to understand when it comes to your anatomy is that your right mainstem, right, the bronchus, goes pretty much straight down. The left one goes on a bit of an angle because your heart's there, right? So you're making room for your heart so that the bronchus kind of swings up a little bit. So if you have somebody who's choking and they're still able to breathe a little bit, it's highly likely that the bolus has gone down to like right about here. If you intubate someone and you only have lung sounds on one side, it's highly likely that you've intubated the right mainstem, okay? So when you have something like that, you need to pull back a little bit. However, You do also need to make sure that the patient has a left lung, or get a good history. Had a patient once who we intubated and we pulled it back a little bit because we were only getting right lung sounds. Patient had a left lung, however, he had severe lung cancer, so there was probably a tumor compressing the left main bronchus, which means that we were never, even no matter how much we adjusted our airway, our artificial airway, we weren't going to get lung sounds. Also, do be cautious when you're putting together your intubation scenario with your tube and the stylet. If you put the stylet down too far, you can actually perforate the airway because it is rigid. There was a situation in Flushing a bunch of years ago where they intubated a patient and they went too far and they perforated the carina, which is right here. So they were still getting some level of chest rise, except they were putting air right into like the pleural space and the mediastinum. And the patient ended up dying from hypoxia because they weren't actually ventilating, the lungs. So you want to make sure you don't go too far. You just need to pass the pilot balloon just past the vocal cords. And trust me, when you get in and you start looking at an airway, you will know exactly, what the vocal cords look like, and like if you are too far or not. Go ahead. It was more of a, air in the mediastinum, which is like that space in between the lungs and, yeah. So it led to a lot of subcutaneous emphysema, which feels like Rice Krispies treats. So the whole like chest area was kind of puffed because the air was underneath the skin. The alveoli are the functional unit, right? So you can breathe in and out as much as you want. If you don't get your air past the trachea and the bronchi and into the alveoli themselves, you're not going to be oxygenated, right? So people who take very small, shallow breaths aren't actually getting, potentially sufficient amount of oxygen into their alveoli. It's in that what's called dead space, because there is no air exchange going on in these locations. Surfactant is absolutely necessary in order to keep alveoli open. It reduces the pressure and then just allows them to stay open. If anyone's ever fallen asleep, like really, really deep, and you're breathing really shallow, and you wake up and take a deep breath and sort of feel like the popping in your chest. I don't know if this is just a me problem, but if you take like a really deep breath, you can actually feel some of the alveoli reopening, because if you breathe very shallowly, they kind of collapse on themselves because they're not being used. You have 5 lobes. Again, the left side, you're making room for your heart, so you're missing a lobe. Remember that. For some reason, people have a hard time remembering that and totally screw up on tests. You will hear like lung sounds in each lobe, or you should hear lung sounds in each lobe, right? Your lower lobes might be a little quieter, just because, you have to move the air all the way down there. Each lung has its own separate pleural cavity. So when we talk about, the pneumothorax, right, you can have it on one side, not the other, because it will just fill that pleural cavity with air. The problem is once that pressure starts to build, it will push into the other side. The mediastinum is the area in the middle between the lungs, and includes the heart and the great vessels. So breathing is actually a very interesting process. In order to inhale, your ribs have to move up and out. So your intercostal muscles constrict, which pulls them up and out, and your diaphragm moves down. Okay, I don't know how many people did the whole bell jar thing back in elementary school, but you have it works by negative pressure, right? So if you pull down, you make that chest cavity larger, the lungs will inflate. And then when you relax, everything kind of comes back in and gently pushes the air back out. So it should be a very quiet process, right? If you can hear someone breathing, that's not normal breathing. It's also important to kind of understand that when your diaphragm moves down and your chest moves up, it also changes where some of your abdominal organs kind of hang out. So your liver and your pancreas are right underneath that diaphragm. So as it moves down, so does your liver. So if you have patients who have experienced traumatic injuries right along that costal line, which is like right here, right, that edge of the ribs, they might have abdominal organ injuries as well, depending on what phase of the breathing cycle that they were in. Important to know that the diaphragm is innervated by the phrenic nerve. Okay. If you have any damage to the phrenic nerve itself, breathing will still occur because the patient's intercostal muscles will still work. If it's like an isolated phrenic nerve injury, the intercostal muscles will still work, but it will not be as adequate of breathing. And vice versa. If you have someone who sustained like a cervical spine injury, where their intercostal muscles are no longer receiving innervation, but their diaphragm is, they will still be able to breathe on their own, but it won't be as adequate as if they had all of their muscles working properly. Give me a second. So going back to that bell jar, right? They do this in elementary school a lot. You take two balloons and they have one opening, and this part on the bottom is supposed to kind of simulate the diaphragm, right? So as it's higher pressure in your chest than it is out in the atmosphere. So as the diaphragm goes down and the chest wall expands, the pressure drops and is less than the atmospheric pressure. So as it drops, the air rushes in. So this is also known as Boyle's law, that the pressure of gas is inversely related to its volume. So the more gas you have, the less pressure it exerts. So, go ahead. Yes, exactly. So, like, you know how when it becomes winter, and that's a different law. That's the temperature law. Henry's, I think it's Henry. As the temperature decreases, your air pressure also decreases in your tires, right? It's when you're in winter, all of a sudden you're like, I need a little more tire, like my tires are a little flat, because the space between the molecules of air gets smaller, so it takes up less volume, and that's why when if you don't touch your tires in the winter, when you go back to it gets warmer out, your tire pressure will be back to normal. Uh-huh. Yes. Like, the world likes to be in equilibrium. It likes to match across the board. So, and that's why I know there's some tires that actually, if you see a tire that has a blue cap on it, those are filled with nitrogen, or because nitrogen, yeah. So like it's not affected to the same extent as temperature as like regular old oxygen or air is. So it doesn't experience as much of a sway in whatchamacallit, in pressure change. So you don't have to, adjust when the temperature's a little colder out. So we talked about this a little bit, I think, last week. Andrew had asked a question between the differences between external and internal respiration. So I'm going to go through it again real quick. So the very first thing that you need to understand is that these things are different. They're often used interchangeably, but they are actually different. So ventilation is the mechanical motion of moving air in and out, okay? You can move air in and out of a mannequin and still ventilate it, but that mannequin will never experience respiration, okay? External respiration is when there is an exchange of oxygen between the outside atmosphere and the capillary beds in the lungs. And then you have internal respiration, where there is exchange of oxygen from the bloodstream to the cells. Okay? So your lungs are interacting directly with the environment, the external environment, which is why it's considered external respiration. And then internal respiration is between your own body cells. Okay? Make sure you remember that, because it makes a huge difference when you're understanding all of the different, different things that we do. And here's another picture for you. Right? I like to say, if you imagine that your body is like a continuous like cartoon loop, and like your lungs are actually just touching the outside environment. And then you have, your internal, where the red blood cells are doing their thing. It does not take a lot of energy for normal breathing, okay? You do get a little bit, you can get dehydrated due to extra breathing because you don't really realize how much water you're actually blowing off every single time that you exhale. But as a whole, you can just kind of chill and breathe and not really think about it, right? You don't have to, you can control your rate of breathing to a certain extent. We don't always do so, right? It happens without us putting a lot of energy into it. Things that will actually cause you to have to put a lot more energy into breathing. If you have a loss of surfactant, this often happens after like aspiration or drowning or near drowning experiences. An increase in airway resistance, right? So your COPD patients, your asthma patients who are having an asthma attack, patients who have maybe really bad pneumonia and they have like airway constriction due to that because of maybe increased mucus production or something to that, or inflammation due to whatever bacteria is working on them or virus. And then you have a decrease in pulmonary compliance, which can be caused by a number of different things. So emphysema, for example, right? All those alveoli start to expand and they don't come back in terms of elasticity-wise. So they have to really force the air out. If you have someone who's broken ribs, right? Their chest wall is maybe a little more rigid now because they're guarding, because they don't want to take a deep breath. So like now they have to breathe a little faster to make up for the fact that they can't breathe deeply. There's a lot of different muscles that are kind of involved in excess, like extra breathing, right? So right here, your sternocleidomastoids, they're the ones that, like, if you take, like, you kind of like feel your neck and you really try to pull your clavicles up, those are the ones who are doing that, right? So they're attached to like your clavicles and your first rib, and they will bring your chest up. I don't know if anyone's ever played like instruments in band, like woodwind instruments or whatever, and had like your band teacher to teach you, like tell you how to breathe. But it's best if you breathe out, not up. If you think of your chest like a rubber band, right? If you stretch and stretch and stretch, it's not going to, it gets very thin. But if you kind of like pull it out equally outwards, you get a lot more space. So it's always kind of stuck with me from band back in the day. You have your traps in the back, right? They help lift your, oh my God, brain fart. Scapula, there you go. Help lift your scapula, and those are kind of attached into the back of your, arms and stuff, and the shoulders, and help move all that up. Your pecs also, they help contribute. Even some of your abdominal muscles, right? Like you really kind of can get a lot of it's helping kind of pull that diaphragm down. So if you're really working, to breathe, a lot of different muscles are kind of contributing, which is why it takes so much more energy. Kind of different the different aspects of breathing. So your tidal volume is the amount of air that you inhale in a normal breath. This is relatively weight-based, right? So a larger person is going to bring in more tidal volume than a smaller person just because they have larger lungs, right? Makes sense. So that's your space here. Right here. Okay. This is when you're not, breathing extra hard. It's just, in and out, no big deal. Okay. So usually it's about 500 milliliters that we move. Okay. So think about the BVMs that we use are 2 liters, right? So you're using you only need a quarter of that to actually get, chest rise. So people who are over there like aggressively ventilating with an entire adult BVM are doing some damage to those lungs, okay? Because they're not really designed to do all of that work all of the time. Then you have your inspiratory reserve volume. So think about when you're like taking a big yawn, right? So you take a breath, you're like, oh, I have to yawn now. And you just kind of take a really big, deep breath and now I have to yawn. Excuse me. Right? No problem. I'm here for you. The word is killer. That is how, like, the maximum amount of inspiration, right? So if you're trying to breathe in really, really deep, take as much air in as you want, like maybe you're, going to go hold your breath underwater, right? That's your inspiratory reserve volume. So the maximum amount of oxygen that you can stuff into your lungs. And that can be, a few liters worth. Okay? It can like end up being up to about 6,000. Do remember that some of that is in the dead space, though. It's not actually inside your lungs. Where? The dead space? Yeah. Yeah, it's about 250 to 300, depending, again, on patient size. Like, really tall people have a little more, dead space than, like, short people. The oxygen doesn't have to go as far. And then you have your expiratory reserve volume, which is like how much you can forcibly exhale. The expiratory reserve volume is significantly less than your inspiratory reserve volume because your body always keeps a little bit of oxygen in your lungs. Think about it. Your lungs are pretty much glued to your pleural cavity, which is kind of glued to your ribs. So you've always have some level of oxygen in your chest wall to keep it open. Okay, so you will never have no air in your lungs. You will always have a little bit going on. It's about a liter or so. And then other things. Really, the most important one that you're going to remember is going to be your tidal volume. Okay, but we're going to go through the other ones real quick. Your inspiratory capacity is your tidal volume plus your inspiratory reserve volume. Okay, so this is again, like, remember you're like a little kid, you're going to hold your breath underwater for as long as humanly possible, and you breathe out as much as you can. That's, right here in your expiratory reserve volume, right? You breathe out as much as you can, and then you go to breathe in as much as you can. So you're filling up your lungs as much as possible. That's your inspiratory capacity. Your normal breath plus your inspiratory reserve volume. They'll measure this in some patients, like, asthma patients and stuff like that. They'll see how much they can breathe in. Patients who have just had surgery, they give them what they call an incentive spirometer, and you have to breathe in as much as you possibly can, and try to control your breathing so that you keep any edema out of your lungs. And then your functional residual capacity is your residual volume plus how much you can get rid of out of your lungs. Is how much is left. Usually it's about 1,000 to 1,200. This, if I'm sure some of you guys have done this. The fire departments like to make you do that test to make sure your lungs are good, and you have to blow out until your eyeballs pop out. That's sort of right here, your functional residual capacity. You're measuring how good your lungs are. Vital capacity is like the whole thing. if how much air you can move with a really big inspiration, and then how much you can move on the expiration side. And total lung capacity is the vital capacity, how much you can move in and out, plus your residual volume, right? So it's literally how big your lungs are. It's the entirety of this. So average adults, about 600 or 6,000 milliliters, 6 liters. Athletes will have more. Patients who are like swimmers, like Michael Phelps, total lung capacity is probably way more than the average person. Any of those elite athletes who do a lot of cardio, they are going to have a little bit more of a total lung capacity than, the rest of us. This is also important. You need to understand what your minute volume is, because this is kind of when you're ventilating a patient, what you're really kind of concerned with, right? You want to make sure that you're providing an adequate minute volume. And your minute volume is the respiratory rate times your tidal volume. Okay? So if you are ventilating a patient at 12 breaths a minute and 500 milliliters of oxygen, I gotta do the math real quick in my head. I'm gonna cheat and do it on the calculator. So 500 times 12, you have a minute volume of 6,000 liters, or 6,000 milliliters, 6 liters, right? Now, if you change that up and you're going to give that patient more breaths, right? So you're still giving them 500 milliliters per ventilation, but now you're going to ventilate them at 20 breaths a minute. Now you're giving them 10,000 milliliters of air, 10 liters of air, right? So that's significantly different. So you want to make sure that when you're ventilating, you're kind of keeping it here in the middle, because that's sort of normal, right? But then if you have a patient who you're like, they're really acidic, we need to blow off some of this acid for them, right? Then moving 10,000 milliliters of air might be adequate, right? But then if you have somebody who is like, listen, like, they're really tight, we need to wait for the the albuterol to start working, we don't want to cause damage or trauma to their lungs, you might have to slow down the breathing a little bit, or give them a little bit more volume at a slower rate. Okay, so this is why it's important for you to kind of ensure that you know what's going on. Again, if you are also if you've taken over for somebody's respirations and their ventilations, you don't want to go from like, oh, well, they were breathing really hard here on this side, but we're going to slow it down really, over here, or, we're going to bring them back to normal. That might not be adequate for them, okay, or vice versa. This is, just something that you need to make sure that you kind of keep in mind as you're, literally breathing for somebody. In terms of the amount of amount of air that gets to the alveoli, you need to change this up a little bit. You would take the tidal volume minus the dead space at 350, right? So if you're giving them 500 milliliters and then you're getting rid of 350 in the dead space, you're only giving that patient like 200 or 150 milliliters of oxygen, okay, times your respiratory rate. So you also need to take that into account as you ventilate your patient. Not something that you're probably ever going to be tested on, but something that you have to understand, especially when we get to like diving injuries and stuff like that, is that the mixture of gases that make up your atmosphere have a partial pressure, okay? The partial pressure is, the sum of the partial pressure of each, component of gas. And that pressure is exerted on everything around you, right? And this is why atmosphere changes when you go up in the mountains and the air is quote unquote thinner. It's because there's not as much of those gases exerting pressure on the lungs, right? So you're not necessarily getting in as much. That's why when you move down under, below sea level, there's more gas on top of you, so there's more pressure exerted, okay? Something that you will need to know when we go into, diving incidents. Is that a question that popped up or just a comment? Mm-hmm. What is it? Go ahead. Okay. Okay. Number one, above all other things, I need you guys to make sure you understand how, like, the system, like circulatory system in the body works. Okay. It's very regularly tested, and as paramedics, you need to kind of understand that. Okay. It's essential. So you have the right side of your heart, right? This is your low pressure pump. Blood flows from your superior vena cava and your inferior vena cava into the carotid sinus and goes into your right atrium. From the right atrium, it goes into the right ventricle and then goes out towards your lungs, right? Through the pulmonary arteries, because arteries always carry oxygen away from the heart. Arteries away. Goes through the pulmonary circuit into the capillary beds, picks up all the lovely oxygen that we need for survival, and then goes back down into the left atrium, into the left ventricle, and then up out through the aorta, goes and hits the carotid. It goes down across into the I'm having like such a bad brain day. Across to your arms, and then goes down into your abdominal aorta, or your thoracic aorta into your abdominal aorta, and goes around your entire body, continuing to flip-flop all of the oxygen and carbon dioxide, and then back to the lungs. And it goes over and over and over and over, right? Your blood can circulate throughout your body like a few hundred times a day, depending on your blood pressure and all that other good stuff. Meanwhile, inside the lungs, you have, air goes in, air goes out. When air goes in and as oxygen comes in, it will go into the red blood cells, and the carbon dioxide will be bumped from the red blood cells and bumped out of the plasma and back in here due to diffusion, and then go back, it will be exhaled back into the atmosphere. If there's anything, like there's some sort of increased space between these capillary or these two walls of cells, right? So maybe you have edema, right, in between. It's going to be harder for that oxygen to be moved. If you have pneumonia, right, and you have maybe some pus or infectious material in here, it's not going to move as well. If this alveoli is collapsed and the oxygen can't get in here to begin with, you're going to have an issue exchanging oxygen. If this capillary is blocked, right, this was the whole problem with COVID, is that it was causing clots, and the clot would cut off the circulation to different alveoli. That's not going to work, right? If you can't get blood into the alveoli and past it, then you're not going to have any gas exchange. So that this little mini circulation needs to happen as well in order to make sure that you have adequate oxygen in your body. So this whole thing works based on diffusion, right? So if you have high concentration on one side and low concentration on the other, the environment really likes to have an equilibrium, so it will try to balance it out. So gases will move from an area of high concentration to low concentration. Henry's law talks about the amount of gas molecules that are dissolved in a liquid. Think about when you open a bottle of soda, right, and you get that right? That's the pressure being released, which therefore means that the gas is not being pushed into the liquid, right? The bubbles in your soda. This is why your soda goes flat if you don't keep the top on, because it becomes the same pressure as the atmosphere, and the gas wants to find its equilibrium, so it balances out, and you lose those bubbles. Those bubbles are being forced into soda. And if you don't close the soda, it will lose all of that, the bubbles. This is sort of the same thing, right? So when you take a deep breath, the carbon dioxide, it does dissolve in the liquid. When it reaches the lungs, where it's not being held under pressure inside your body, it diffuses back into your lungs and escapes from your body. there is what we call the oxygen dissociation curve, which is sort of right here. So basically, have you ever noticed when you give a patient oxygen and they're like at 99%, it doesn't necessarily pop right up to 100? Maybe it takes a little while, maybe they chill out at 99. Basically, the body's like, it takes a lot more oxygen to push you these last, as this curve flattens out, it takes a lot more oxygen to kind of push you up. But if you have a patient who's like, SpO2 is like, down here at like 50, and you give them oxygen, they're going to pop right up as quickly as possible, or really fast, because, the oxygen is looking for, the red blood cells are looking for oxygen in order, like, to adhere to. For the most part, like 98% of your oxygen is transported being bound to hemoglobin. It's just a good affinity there. If you have a patient who has a low hemoglobin, they can potentially have, an SpO2 of like 98%, but they only have like 4 red blood cells bouncing around, or they have a low hemoglobin, right, or iron deficiency, and they're not actually getting as much oxygen as you think that they are getting. Mhm. 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 Yes, you can. It might not do much. If they're short of breath, the increased oxygen might not help them. If they have healthy lungs and stuff, if what they really need is like, maybe a blood transfusion or like an iron pill or something to really kind of fix that issue. Make sense? Witness protection came and took Rob, guys. Hello? Okay. Yeah, he has. There you go. Oh, he's back. Mhm. 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 No, pretty much. Yeah, exactly. Exactly. Mhm. Mhm. I didn't either. That sounds very turbulent. Where was that? Oh, it's expensive. Mhm. Yeah. Mhm. He probably was like really happy to be off that awful nasal cannula. Uh huh. Yeah. Yeah. Mhm. That's wild. That is cool. I've never seen that before either, because we they teach us in they've been teaching us forever and a day, like, you don't put a nasal cannula at more than 6 liters because you're going to be, it's very rude. Like, the patient's nose is going to get, dried out and they're going to be uncomfortable. Meanwhile, like, 30 liters of oxygen. That's nuts. Mm-hmm. Wow. Yeah, I honestly am not sure. I feel like there's some sort of science that either they aren't sharing with us or they are making up as they go along. Um, I don't have a good answer for that, unfortunately. Yeah, I don't. I don't think I've ever seen a regulator go over 20, maybe 25. Mm-hmm. 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 If anyone could get a picture of that setup without breaking HIPAA rules, the next time you're doing like a transport, I would love to be able to see that because that's pretty wild. Oh, it's totally a thing. So, and we talked about this a little bit with like when we're doing reperfusion. Um, you can create oxygen toxicity. Most of the time, when you're taking a patient for like a 10-minute stroll down the block to the hospital, you're not necessarily going to be putting them there, but you can push someone beyond, like if it says he's down here like the pressure of oxygen, you can push people into like the arterial blood gases and like the 200s and stuff, um, which it's like whoa, that's too much because it starts causing free radicals and all sorts of other things where you can end up with dysrhythmias because anything and too much of a good thing is still a bad thing. um, and this is sort of why you kind of, we don't do arterial blood gases, so you're going to kind of monitor your patient, be like, okay, um, they're not having difficulty breathing right now. I can lower the liter flow, or okay, the patient is, the pulse ox is 70. Let's bump up the liter flow. Um, it's kind of just making sure you're watching your patient carefully. Like patients who are 100% and not have SpO2 and aren't having any difficulty breathing don't necessarily need a non-rebreather or a nasal cannula, you know. But if they're, 80% and having a hard time breathing, you can, you should treat that. Huh? Okay, cool. Hold on. Can you share it? Oh. Yeah, put in the group. Mm-hmm. All right. In the meantime, while waiting for that to pop up, he does look very menacing. He looks like that car insurance commercial, and they black out the people's faces because they're saving so much money. So, kind of playing into diffusion a little bit more, right? So you know you need to have oxygen, a high concentration of oxygen will switch, but you also need to have a secondary, okay, you have to have that secondary gas in order to create the diffusion. So the other one is carbon dioxide. So carbon dioxide, like the majority of carbon dioxide, is dissolved in plasma, okay? And it's transported as carbonic acid and bicarbonate ions, okay? This is like, they love to ask this test question, like, how does carbon dioxide transport in the body? It doesn't bind itself to red blood cells. A little bit, but not significantly. Most of the time, it's dissolved in the plasma as carbonic acid and bicarbonate. So this is important because when you think about, when you have patients who aren't breathing, right? You're choking patients, cardiac arrest patients, people who have, some sort of obstruction or they're not able to blow off oxygen really well, narcotics users, right? This is why they become acidic, because that carbon dioxide dissolves into carbonic acid. And that's why it's so important that they're ventilated appropriately to get rid of that acid. The carbon dioxide does reconvene back in the lungs from being carbonic acid and bicarbonate into being a carbon dioxide molecule. Carbon dioxide is determined by like how much your metabolism is going. So like if you are just chilling on the couch, you're not going to produce as much carbon dioxide. If you are going out for, doing a Tough Mudder, you're going to produce way more carbon dioxide. This is why, your body will appropriately cause you to breathe faster when you're exercising rather than when you're chilling on the couch. Not something that you need to memorize at all, but the Fick principle is like what your like oxygen consumption is. But you need to have adequate amount of oxygen in order for it to combine to hemoglobin, right? So if you're in a low oxygen environment, right? Going back to the weird true crime stuff, right? If you've been buried alive, you only have a certain amount of oxygen within that little box that you've been buried in. So as even if you stay calm and you don't consume too much oxygen, eventually the atmosphere will have an inadequate amount of oxygen for it to be more than the oxygen in your body, right? So that diffusion is not available because your atmospheric oxygen is lower than your body oxygen. You cannot be well oxygenated if you do not have sufficient number of red blood cells. And not only red blood cells, but an adequate number of hemoglobin on each red blood cell, right? So patients who are hemodynamically compromised, right? Your shock patients, trauma patients who have lost a significant amount of blood, your severely anemic patients, right? They're not going to get the appropriate oxygenation that is potentially required for life. And on top of that, in order to be adequately oxygenated, you need to make sure that the oxygen can make it through the alveoli epithelium and the pulmonary capillary epithelium, right? That's two tiny cells that it needs to get through. However, we talked about, right, if there's pulmonary edema, the oxygen's not going to be able to travel through. If there's some sort of infectious process and there's pus or something, it's not going to be able to get through. If the pulmonary capillaries are blocked or restricted, it's not going to get through. If the alveoli are not able to expand because of lack of surfactant or because of, an an inflammation, like an anaphylaxis or asthma process, you're not going to have adequate oxygenation. And we talked about a number of these already. VQ mismatch, this is what happens in your pulmonary embolism. Right? This is probably, it happens all over the different place, but the best example is a VQ mismatch, which is your ventilation and perfusion mismatch. I know Q really is how you spell perfusion these days. Basically, you're either, your ventilations are appropriate, but your perfusion is not, right? So if you have like a massive blood clot in your pulmonary arteries, you can breathe in and out as much as you want, but the blood isn't getting to the alveoli. Or you have great perfusion, but your ventilations don't match, right? So your narcotics users, right, who their blood's going round and round, and it's like, hey, I'm looking for some oxygen, but their lungs, aren't getting the message that they should breathe. That's right here. And so any mismatch of that will affect how well your blood can be oxygenated. Some chest wall abnormalities that are kind of note, right? Especially older patients, right? If they have that kyphosis, that really hump back, their chest wall is not going to be able to expand as well as you would expect, because it's just kind of crunched. Paralysis, we talked about. Okay. You can control your respirations to a certain extent, right? You can control how much you want to breathe, but for the most part, it's involuntary. It's in your medullary respiratory center. Your vagus nerve, glossopharyngeal, and somatic nerves are the ones that kind of contribute, right? They give you an idea of what your body's needs are. And then you have chemoreceptors, which detect how much oxygen, carbon dioxide, and hydrogen ions are around. So your body can make very careful adjustments to how much you need to breathe so that you don't become too acidic or too basic. Because no one wants to be a basic bitch. Fun reflexes. Your Herring-Brewer reflex is really cool in so much as it prevents you from popping your own lungs by over breathing. Right? So you will get to a certain point when you're taking a really big deep breath in and then your body's like, yeah, no, that's enough, because it doesn't want you to pop your lungs. Your pneumotaxic center also helps prevent overinflation when you're breathing really hard. It's sort of like just the chill, like, okay, that's enough. Like, let's not breathe too much. This when like you start to catch your breath when you're like after exercising, you're starting to catch your breath. This is what helps you slow down your breathing. We commonly breathe by hypoxic drive. Yes or no? Okay, good. Your body commonly detects when you have too much carbon dioxide. Okay, so you're going and you're exercising, and now your muscles are using extra oxygen and creating extra metabolites. So now it's like your body's going, we need more oxygen. So you start to breathe harder. When a patient switches into hypoxic drive, it's because their carbon dioxide is just too much, right? These are your COPD patients for the most part, right? There's just too much carbon dioxide that it's no longer accurate for the body to say, oh, we have too much, we don't have enough oxygen, or we have too much carbon dioxide, let's get rid of it. Now it needs to say, we don't have enough oxygen. So this is why, like, you can have COPD patients who are chilling with an SpO2 of like 82, right? They're just sitting there like, yeah, no, I'm okay, I'm a little short of breath, but nothing terrible, right? And you're looking at them going, you're kind of gray. The body, like, is very adaptable, okay? The body wants to be alive. It doesn't want to, deal with issues where, all of a sudden it's not able to survive. So it will switch. pH also, right? We talked about how carbon dioxide affects your pH. So there's a number of things in normal respiration that your body does use. When we're over back in the hypoxic drive, like these patients might have pH imbalances, right? Because they're just here with too much carbon dioxide. Their kidneys are going to have to work harder to try to get rid of this because their respiratory compensation isn't going to be as effective. We talked about a bunch of this already, but as patients get older, you also have other special considerations that you need to kind of take into account, right? As you get older, you lose a significant amount of not only muscle mass, but elasticity, okay? Like 80% or something ridiculously high of lung compliance due to decreased elasticity happens as you start to get significantly older. The muscles, those intercostal muscles, start to get a little weaker, right? So that means that you have a just not as good compliance with the chest wall because they can't be as effective. Brittle bones, right? So if you don't have a strong bone to pull against, the chest excursion isn't going to be as significant, so you're going to have more issues. The whole perfusion, ventilation, gas exchange, right? So your diffusion might change a little bit, especially if there's some sort of comorbidity going on. Surfactant production might decrease, so your alveoli surface is going to be lower. Increased dead space, right? You might have some alveoli that, the perfusion to the lungs is not as good, so the alveoli are working, but there's not necessarily as much capillary availability. I think we all kind of see the people get older, they aren't able to exercise quite as much. Everything becomes a little less efficient. So that capacity gets lower, so people start to slow down. Your chemoreceptors start to be a little less sensitive. Cough reflex. This is huge. This one right here, a decreased cough reflex. This is why older people get aspiration pneumonia so frequently, because water, food, all sorts of stuff can now sneak past that epiglottis and the uvula, or all that stuff back there that kind of causes you to cough and gag. It sneaks right past and goes right into the lungs, and you have patients who get serious cases of pneumonia. So, it's also kind of associated with the fact that as you get older, you may or may not have your own teeth anymore. So it's harder for patients to chew, so they have larger food boluses going down, which can cause issues. Also why older people can choke more often. A lot of different medications that patients are on might decrease how much their breathing rate, right? They're on pain meds, they're on beta blockers. All of that stuff can decrease the ventilatory drive. And kind of in combination with the cough reflexes, a lot of the little cilia and stuff, they kind of get a little sluggish, right? They're a little tired. They don't want to do as much as they're usually doing. Patients who smoke especially are going to have paralyzed cilia in the airway. That's why, they get sick, and when they cough, they get that rattling noise because stuff can't move upwards because those little cilia are paralyzed by nicotine. And your immune function also starts to decline. So now you've got, whatever you've aspirated in your lungs, and your body can't pitch as enthusiastic and immune response as you would expect. Any questions before we move forward? Don't get old. It's the best thing I could tell you. All right, a few different things. We talked about this a little bit in terms about the right main stem. Foreign body airway obstructions, right? Basic BLS. Patient can cough. Don't do anything. Let them continue trying to cough. If they can no longer cough, then you are going to do your Heimlich maneuver, or as we like to call it, the abdominal thrusts, because we decided we're not going to call it the Heimlich maneuver. Ironically, the gentleman who did invent the Heimlich maneuver saved one of his nursing home when he was old. He actually just passed away like a year or two ago. Right before he passed away, he actually performed the Heimlich maneuver on another one of the nursing home residents he lived with and saved their life. So I guess he gets some kudos there. Kids. Yeah, that's why we're calling it abdominal thrust. I don't remember why. I think people getting a little bitchy about stuff. Seriously. Hashtag he's too German? I don't know. So kids love to put stuff in their mouth, right? So you're choking victims are commonly children. Most of the time it's not food items. Hot dogs are deadly for little kids, right? Those need to be cut very small if you're going to let a kid have a hot dog. Grapes also very in terms of food, very dangerous for small children. Bic pens, if you ever look at a Bic pen, they actually have a hole in the tip of the cap so that in the event that a child does swallow it, that they can still breathe a little bit. Right? Like little stupid things that you never realize. You're like, oh, why is there a hole in here? Now you know. Rainbow. Unconscious patients, you end up having to do a little bit more work. McGill's forceps are the things that you're going to kind of end up learning when you get back to labs. If you get to use a McGill's forceps, like, it's kind of awesome because, like, you very rarely get to actually use them. This is the point in time when I tell you that carbs kill. It is a lot better for people if they choke on meat boluses, because the second you try to pull bread out of an airway, it just sort of crumbles because of all the moisture, and you're there like really trying to scoop rather than pull. It's disgusting. If that's the case also, I might even recommend, if you do know that someone's just choked on like a piece of bread or something, to just intubate them and suction, instead of trying to like screw with the McGills, because you're probably... You might be able to. I would say put a tube down, because then you can use the tube to guide the suction catheter. Because first of all, you're going to need two hands to use the McGills, because one hand's holding the laryngoscope blade and the other one's holding the McGills. So you're out of hands. One. Two, once you get the tube in there, you can do deep tracheal suctioning. We recommend, right, we don't like to let you use the Yankauer to suction further than you can see, which is really just like the oropharynx. So you because it's a little too much suction. So you kind of end up in like that kind of gray area of like, maybe not. So you use the French cath down the tube, and that's approved. Because the thing is, you can also put, I don't know if anyone's ever dealt with into their trached patients. They have what they call these little saline bullets. They're little pink guys, and they usually they shoot that saline down to help break up mucus plugs for patients who are like chronically trached. And then they send the suction down, and the patient makes this horrible, hacking, nauseous, vomity looking face where they're coughing and like they're not making a noise because they, not accessing their vocal cords. You can do something like that. Similar, you can put take a saline flush and push a little saline down the tube to loosen up whatever bolus is in there. Yes, if you can push. So if you look at your protocols for foreign body airway obstruction, it's basically you look. If you can McGills, you McGills. If you cannot, you intubate the patient. If you ventilate the patient after ventilating and no air goes in, you deflate the cuff on the tube, push it down as far as you can, because they're thinking that, hey, you're going to now push that bolus into the right main stem. You pull back until where the measurement line on the tube is back where it was originally when you confirmed the tube, and you try to ventilate again, because one lung is better than no lungs. Mm-hmm. Correct. Or ventilate the left lung, and then the patient, Yeah. And then you bring the patient to the hospital, and they'll do a bronchoscopy, and they'll pull that bolus out. Mm-hmm. Yep. Yeah, and theirs goes like way further. Yep. Yep, very similar. So one of my former medic students, who's also now a friend, was working at Jamaica and had a patient who was choking, and he actually got to use the McGills, and I was super jealous because I have only sort of been able to use the McGills once because I was working in Melville and one of the chiefs was a CC and he got there like half a second before I did because I was on another job. So he was using the McGills and I was like trying to kick him away, like, no, it's mine now, it's mine. So he ends up going in and the lady was choking on an Eggo waffle. And I was like, if you did not say, let go my Eggo as you pulled that bolus out, I'm going to be very disappointed in you. Alas, he did not. Professionalism. So if you get to actually use a McGill's, it's kind of a highlight for the most part. Like, you don't really get to use it very often. So airway obstructions can be caused by a couple of different things other than a foreign body airway. Tracheal trauma is very serious, but very rare. Most of the time you'll see this with someone who's maybe been punched in the trachea or has been involved in a car accident unrestrained and has taken the steering wheel to the trachea. But most of the time you're still going to be, you need to do C-spine for that. It's not going to be like an isolated injury. Most of the time it's at the cricoid cartilage, and that fractured, like that injury right there could be a combination of like a fractured larynx where it's just collapsed, or a hematoma in the area that's like crushing down on the trachea, or something else like subcutaneous emphysema where it's broken and all that pressure is now making the trachea like just restricted. Yes. Yeah, like a little more direct injury. I'm doing like the knife hands to the throat in case you're missing, because I know you can't see. Knife hands to the throat, kind of like very directed. The whole trachea, the whole larynx kind of collapses. Your patient will have a hard time talking. It'll be maybe a hard time swallowing because of like the injury to the area. And then you have laryngeal spasms. So it's commonly seen, laryngeal spasms are commonly seen in like patients who are drowning, because your body does this really cool thing where it goes, oh no, water, we don't want that in the lungs, and clamps down your larynx. So it'll clamps down like your whole vocal cords to keep the water out of the lungs. Body's pretty cool. But you can also cause it by like aggressively attempting to intubate. Though most intubation looks super aggressive, you can be kind of gentle. A lot of swelling in that area is caused by like if you're like hitting the tube along the sides, or you're not being careful with the blade. These are all things that can also kind of cause a lot of swelling and spasming in that area. Aspiration is below the glottis, right? So a foreign body airway obstruction is commonly above the glottis. When it moves below the glottis, it's considered aspiration. So there's a lot of different things that can cause this. A lot of times drunks, right? Drunks who vomit in their sleep can suck all sorts of like nonsense into their lungs and cause a lot of damage. Any other like patients who've had a stroke, patients who have hypoglycemic patients, right? They can end up aspirating all sorts of stuff into their lungs if they're not in a position where they can drain. Weird anecdotal, patients, I've noticed when patients go into hypoglycemic comas, they tend to, if they're sitting, they end up leaning forward a lot. Like their body's like, no, we're not going to die. But patients who have like significant brain bleeds while they're sitting end up going backwards, and their brain's like, no, we've tried. It's like, I'm sorry. Totally anecdotal, but that's what I've noticed in my career thus far. So aspiration, basically nothing should be in your lungs except for oxygen. So if you have something that's like significantly acidic, right? Vomit is particularly acidic. That's going to cause a lot more damage. If there's any sort of like bacterial contamination, or like just the sheer amount can cause can kind of change how bad the aspiration and the aspiration pneumonia are going to be. Questions, thoughts? Mm-hmm. 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 I think so. Yeah, I'm pretty sure. I'll see if I can find it with the names because I'm not sure. I'm gonna make a note. Okay, I will see if I can find out what that is called. But yeah, they do to like. So if you ever see like the patients who get morphine in the hospital, if you slam it too fast, they'll get nauseous. I think it's sort of like the same mechanism. So yeah. Any other thoughts or questions before we move on? Mm-hmm. 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 It is a thing. I've seen respiratory therapists do it. Um, the problem with that is, well, there's two problems. One is that if you need to ventilate in between, it's a little harder to make a good seal because that extra tube is there. And two, the possibility of creating a stomach contents geyser is very strong. So, but yeah, pretty much you've blocked the one hole. You only have one hole left to go in. Um, However, you also need to remember that the esophagus is very elastic. So even though you think you're in, you still could be in the stomach yet again. So it's why it's important. You really need to visualize. And there's a number of different ways and tricks that like I can tell you about. I had to position yourself and the patient so that you can see the airway better. But we'll talk about that in a little bit. Kink tube. It's just less likely that you'll be covered in vomit. I mean, unless you want to go home early. Like, I gotta go home. Why? I'm covered in vomit. Any other thoughts, questions? All right, cool. This patient, does he look okay to you? Oh yeah. So right, we got that. We got some pursed lip breathing right there. Um, I've had some students say before that they think he looks cyanotic. I think that's just he's not shaven. You can see. Look at the retractions. You can see his ribs, right? Those retractions are him trying really hard, right, to use his intercostal muscles to expand his chest. His shoulders are up, right? So now he's using these accessory muscles to try to expand his chest. There's a lot of, and you'll know. Like I think everyone, for the most part, you walk in, you go, this patient's having a hard time breathing. I think one of the scariest patients who you're like, oh, they're having a hard time breathing is when they're very quiet and they're very tired looking. They might not look serious at first, but they are probably the most serious patients you're going to deal with because once they start looking tired, they're going to crash. Okay, so you need to really, once they lose that like, that will to live and they just start looking tired, you're going to be, breathing for them very quickly. Gasping, right? Always nasal flaring is very commonly seen in children, right? Because they're obligatory nose breathers, so you're going to see that there. Getting a good history, right? You got to make sure that when you're talking to the patient, you find out what's going on. Was it a sudden onset or a slow build, right? So if you have a patient who's got a history of asthma or something, they might have been like, yeah, I've been having a hard time breathing all week, but, I take my inhaler and it got better, but it's just not getting better today. That's a slow build, right? Versus somebody who's like, I was, just sitting here and all of a sudden I had a sharp chest pain and I had a hard time breathing. Right? So those are significantly different scenarios. What makes it better or worse? Most of the time, patients find that breathing is a lot easier when they're sitting up and leaning forward, right? If you have patients who are complaining of a hard time breathing and they're laying flat on their back, it's probably something else. Like it's patients will try to position themselves in a way that makes it easier for them to breathe. Or it's an anxiety attack. I've seen that a lot. I can't breathe, right? And they're having a full-blown anxiety attack and they're laying flat. And you're like, all right, let's get you sitting up first, okay? What other symptoms, right? Do they have a fever? Do they have chest pain? Do they have swelling in their ankles? All of these things mean, different things. And this is, helps you build a differential diagnosis so that when you start treating them, you are accurate, right, in what you're doing. Previous treatment, if you have a patient who has COPD or asthma, 5-meter dose inhalers are equal, pumps are equal to 1 nebulizer, right? So and a lot of times patients' doctors will tell them that. So you'll be there and they're like, yeah, I took 10. So basically that's the equivalent of them doing 2 nebulizer treatments, which if they're, when you say, oh, you're supposed to take it as you're prescribed, technically that's a prescription for them because their doctors told them, like, if you get really bad, do this, because they might not be able to have a nebulizer because of insurance or any other number of ridiculous things. But, are the patients taking their medication the way they're supposed to? There's a lot of patients who are like, oh, well, my blood pressure is good, so I don't take my medications anymore. Or, oh, I only take birth control if I'm going to have sex. Doesn't work like that. So, you want to make sure that patients are taking things the way that they're supposed to. People are surprisingly more stupid than you think. Recognizing different respiratory patterns is also super important. The ones that you're probably going to see the most are your, that are not here where you're like tachypnic, where they're breathing really fast because they're septic, or they're hyper, I can't, nope. Mouth's not going to do it. When they're like having like an anxiety attack, they're over here. Is you're going to see patients who are doing like ataxic breathing, which you see patients who have a bad brain bleed or head trauma. They'll like breathe really, really irregular. Your Kussmaul's, which you'll see with your patients who have DKA, and Cheyne-Stokes, also you'll see with head trauma as well. Kind of like, yeah, people who are like, I have to do something for you. I was standing in the triage at Jamaica Hospital one day, and this FDNY crew brought in this intox. His head's all wrapped up, and he's going, and he's breathing poorly. And I'm like, what's the story? What you got here? And they're like, just an intox. I'm like, when he lose consciousness? Oh, no, he's just sleepy. Guy's out. GCS 3. And I'm like, I just walked right into triage. I was like, hey, you have a trauma note. And they're like, what? I'm like, yeah, I'm going to have it. And I literally told them, like, go to the trauma side right now. He's a note. Guy had a huge brain bleed. But we didn't recognize it because he's, quote, just an intox. Always be careful with your, quote, just an intoxes. So basically your body's trying to compensate for whatever's going on. If you've whacked your head really hard that you're, bleeding into it, you might have affected your respiratory drive center, which is why you have a strange respiratory pattern. Or your body's trying to decrease intracranial pressure. Kussmaul's is commonly caused because its acid level is too high. Your body's trying to blow off as much of the acid as possible. So make sure that you kind of familiarize yourself well with the different respiratory patterns, so that when you have them in the field, you're like, oh, I know what this is. This apparently means nothing anymore because of COVID. So, here, this is for your edification, not really. Nasal cannulas do whatever they want. I don't even know. CPAP is the duct tape of respiratory fixes. Okay, so basically you have a patient who's having a hard time breathing. You can put them on CPAP and they'll feel fantastic for the most part. A lot of times patients have the problem they have with CPAP is they can't tolerate the mask. Think about rolling down your windows and sticking your head out at about 60 miles an hour on the highway. That's kind of what CPAP feels like. It can be very overwhelming. If your patient is conscious enough, or they have to be conscious, but if they're like with it enough where that they can work with you, they're not too short of breath, I like to give the patient the CPAP mask and say, all right, listen, together we're going to put it on your face and let them kind of get used to it, over a little period of time, like maybe a minute or so, until you can actually put it on and create a good seal. Patients really appreciate that, because then not only do they feel better, but they don't have that like high level of anxiety and overwhelmingness that, you know, when you just slap a CPAP mask on people. People don't understand that for some reason. Basically what it does is it's constant positive pressure. It pushes all of the alveoli open, and that based on that pressure, anything that's in there like fluid or mucus or whatnot gets kind of pushed out to the sides. Really works well. You'll see people, it helps prevent people from needing to be intubated. Well, intubation is kind of like awesome on our, like, you know, if you think about it on our side, I get to intubate somebody today. The second that you take away the your like autonomous control over breathing, all of those muscles start to weaken. So 1 day ventilated is like 3 days of needing to rebuild muscle, which isn't bad if it's a young person, but the older someone gets, the less likely that those muscles are going to recoup as much as they should. And weaning off a vent is a horrible process. Okay, my grandmother was on a vent for like a year and a half, and it took a lot of effort and a lot of energy for her to like regain all of that breathing, you know, and even then she had a hard time like with like coughing and like that gag reflex. Commonly you're seeing the constant pressures at anywhere from 5 to 10 centimeters of water. You can go a little higher, but it starts to become a little uncomfortable for the patient. If you have to start low and work your way up, that's suggested rather than just slapping them here at 10 centimeters. The difference between BiPAP and CPAP is that BiPAP gives you 2 levels, right? So you have to now exhale against 5 to 10 centimeters of oxygen pressure, as opposed to here where you have an inhalation period where it's 10 centimeters and an exhalation period of 5 centimeters. You're still keeping the lungs open effectively, but you're giving, you know, the patient a little bit of a reprieve here so that they can maybe breathe out a little bit better. PEEP, which is, you'll hear a lot. PEEP is just a great word. Positive end expiratory pressure is when you're doing your positive pressure, right? Like basically it helps simulate what your body normally does to keep your lungs open, like that positive pressure that your body needs. When we talk, you see that, hold on, go back to here. So this patient here with a pursed lip breathing, that's called auto PEEP. When you purse your lip, you're sort of making the airway more, you're adding resistance to the airway to keep the lungs open. So that's why COPD patients do that. It's called auto PEEP. As opposed to now here in, you know, a mechanical world where we set the PEEP, it's usually 5, to kind of help keep that alveoli open on the other side. Various mechanical ventilation options. We usually live here in the BVM section. You can take the mask off of BVM and ventilate a trach. You can get a pediatric mask and ventilate a stoma. Transport vents, always a blast and a half. If you are working in the 911 system, you are technically not approved to operate a vent because it is outside your scope of practice currently in New York State. So you need to have someone come and, quote, take responsibility for the vent, which basically means that if there's a nurse or a parent, they are the ones who are in charge of the vent, okay, so that you can keep the patient on it throughout transport. It's a little more comfortable for the patient. If no one wants to take responsibility, then that means that you're going to disconnect that patient from the vent and use the BVM to ventilate them. Okay, so a lot of people don't want that to happen. So this is when you kind of need to convince them to take responsibility. We're talking about the 2 tubes. So first of all, I don't know about anybody else. 3 tubes. Would you have put an NPA in this patient? Thank you. Thank you. Terrible plan. Terrible, terrible plan. Yeah, I mean, he doesn't seem to have much of a nose left, so we use whatever, I guess it's our safety pins from the T bandages, right? You're going to use that to keep it in. I do not. It looks like a gunshot wound to the face, honestly. I just found it and was like, this is a great talking point. Yeah, if you look, looks like great. This actually might be the exit wound. Hard to tell. But, so now, let's talk about this tube right here. So, he has been tubed with an 8.0, right? All your information's right here on the side. He has been tubed with an 8.0. There's some blood in the tube. You can see up here, there's some blood, right? He might have aspirated, but this patient in particular definitely needed to be tubed because look at all of this blood. Can you effectively keep this airway clear? Nah, it's just messy, right? Also, if he's bleeding from his airway, the pressure of the pilot balloon might actually help stem some of that bleeding. Double purpose. With whatever lip he does have left, he's 28 at the lip line. This tube is probably a little too deep. Should probably be closer to like 26. Granted, his anatomy is a little messed up right now, but often you have just like a little bit more. This is like a very deep tube to me. He might be a very tall patient. The problem is that the 8.0, it's a little longer than like a 7.5 or a 7. So, you know, I don't know. It just looks too deep. You've got good condensation, right? So you know you're in the lungs. Look at like that white misty, right? Great condensation. Secured with looks like a shoelace. Tape is clearly not going to work here. Even the manufactured airway, they kind of rely on a intact mouth or at least gum line to kind of work. So this really looks like the best option that they had. You can see right here they're holding manual stabilization because this guy's probably going to get a C-collar. I know Suffolk, they're like, put a C-collar on any patient that you've intubated. I don't necessarily agree with that. Because sometimes it actually is beneficial to turn the patient's head and put the BVM down on like the scoop stretcher so that you don't lose your airway whenever you're moving. I'm going to say right now, every time you move a patient that you've intubated, you need to double check your airway. I don't care if it was from the bedroom onto the scoop, the bedroom floor for the scoop, or it was down a flight of stairs, or it was up a basement flight of stairs, or, getting them into the truck. You check that tube. The second you have somebody's airway under your control, you need to be obsessive about it, okay? Because you know what happens when you get to the hospital and that tube is dislodged? It's your fault. No matter what. It could have been, the doctor could have come and yanked that tube out of his throat and they still would blame EMS. So always, 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 every time you move a patient, make sure it's still where it's supposed to be. So going back to some of the tricks of the trade a little bit, this right here is going to be more difficult to intubate than here. Here you have like a straight line going right down, okay? It's a little easier to see. What I used to do, what I like to prefer, is I actually take this bolster. If you have a patient who doesn't have any C-spine precautions, actually stick it right in between their shoulder blades, because then the head drops back, especially if you're intubating on the floor, because you have to get low. Like you need to do some crazy-ass yoga moves to get that low in order to see the airway. If you bring their shoulders up, it brings the whole, basically you want to put this whole, you can't see me, you want to put the airway in line, right? It should be a straight line. It shouldn't be like kind of V-shaped like this. This has even got a little bit of a V-shape, but it's a lot straighter because you're going straight down into the mouth. But if you kind of level it so it's like all across one plane, it's easy peasy. Which one, the bloody guy? Carefully. I don't know if I would use an 8, basically. I don't know how big this guy is. He doesn't look particularly large. I probably would use a 7.5. So basically, another trick I like to do, you take the patient, get them on the stretcher. You sit the stretcher up at about 45 degrees and you sit in the captain's chair. It's pretty much establishing this position right here, that sniffing position, but you're just moving the stretcher, not the patient. This I would have my partner with the Yankauer, and I would just have them ventilate the patient, and then I would have them put the Yankauer right in the mouth and suction while I try to see, because you're going to have a lot of blood in that airway. No, just because you don't know what other trauma is going on in there, and that there's a good, so like look at where this tube is chilling between two of his teeth. There's a strong possibility he's got teeth in his airway. So even you put the king tube in there, you might not get good ventilations because you have a tooth in the airway. So by actually going in and like getting a visualization, like if you 100% can't get it, then you can't get it. Put in a king, nothing wrong with that. But I would at least want to get a visualization to make sure that it's as clear as possible before, I go to a secondary measure. The king is not going to protect from all the aspiration of blood that's going on there. He just messy. Mm-hmm. You could try to suction, but then the McGills. You can use the McGills to play a little game of Operation to get his teeth out of there. Other fun story, Brentwood Ambulance brought in a patient once to Southside, and they're trying to ventilate, tried to, the patient couldn't get it, just went BLS maneuvers to the hospital. They get there, respiratory therapist pulled the patient's entire upper dentures out of their airway because they had pushed it so far in. So be careful. Dentures can be helpful in terms of when you're intubating because it gives the mouth a little bit of structure. The one thing that you're definitely going to play when you're first learning how to intubate is, did I hit the teeth? $5,000 for every time you break a teeth. It makes a clicky noise, and we joke about it for the rest of the class. Totally normal when you're first learning. But sometimes you can take, if you take patients' dentures out, it can be helpful. You have a little more room to maneuver. But usually recommend leaving the dentures in place. Any other questions? Talked about that already. Always do your BLS before your ALS. There's plenty of people who are like, let's tube, and you're like, calm down. Like, let's ventilate first. Or have it just put the patient on oxygen. Always an issue. Remember your head tilt chin lift, super, super effective for your non-suspected spinal injury patients. Jaw thrusts, also super effective. Jaw thrusts can also be helpful while you're intubating, especially if you have a patient who does have a suspected spinal injury, because you can get right underneath the mandible and push forward and get the get your laryngoscope in there a little bit better, a little easier, especially if you have like a really juicy tongue. Suction's awesome. We like suction. 300 millimeters of mercury when clamped. Make sure you check your suction device. Suction on the way out, no longer than 10 seconds. Deep trach suctioning, you will use the French catheter. The term lung butter is one that you'll probably become familiar with, especially if you do transport. What was that? It is. It's thick. It's definitely thick. Ugh, gross. I would have gone home. Like, I don't care. Lung butter is one thing. The second it's in your hair, it's like, no, I'm done. And I've pulled brains off of people, not me, other people. I've had like blood on my arm. Like, I had a meth head like take a bloody hand and swipe it down across my face, and I'm like, I'm good. Lung butter in my hair, I don't think I'd be okay. We teach you how to, I do believe we teach you how to do your orogastric and nasogastric tubes. Again, use with caution in trauma patients. I have seen OG tubes end up wrapped around patients' brains in hospital imaging. It's wild. Basically, if the patient's being ventilated but you don't intubate them right, you don't seal off that stomach, you can reduce the pressure in the stomach so that you don't get sprayed with the stomach content geyser. Y'all military people, crazy. You wouldn't get me enough money in the world to put an NPA in my nose. I think we all had enough issues with corona. You can. You can. I'm good. Yeah. y'all crazy. Remember, no facial trauma suspected, because really nothing quite worse than actually, I don't know, ventilating somebody's brain. Edge of the nose to the earlobe is where you measure from. Lubricate. I remember in EMT class we were taught, like, if you don't have lube, like, you can use the patient's own, like, oral secretions. I did this in front of my medical director here at Winthrop, and he's like, "What are you doing?" I'm like, "It's her goo. She's good." And he's like, "You're going to give her a sinus infection." I'm like, "She's seizing. I don't think that's her biggest problem right now." So yeah, doctors get a little agitated if you don't have lube. Which was kind of funny though. OPAs, right? Really good. These are also really good if you are going to use it as a bite block, if you have a patient who you've intubated and sedated and intubated, because if the sedation starts to wear off, they're going to try to chew on the tube and then you can't ventilate them effectively. So it also helps kind of keep the tube in place as well. So it's good to put those in there. Hopefully we all remember how to do that. Edge of the jaw to the mouth. Edge of the mouth is how you measure. Endotracheal intubation, okay? This is your quote-unquote definitive airway. So when you guys do your CPR again, right, we talk about how you breathe twice every 30 pumps. This, you can breathe continuously once every 6 to 8 seconds. This is really good for patients who can't protect their own airway. You know that they're going to need artificial ventilation for a prolonged time, right? Your respiratory arrests, cardiac arrests, patients whose airway might be restricted based on anaphylaxis, right? Or maybe, some sort of tracheal edema or something going on, where you need to make sure that you're putting something in there that cannot be, that will keep the airway open even if it's a lot of swelling. So we talk a little bit about the balloon pump, right? The pilot balloon. This is the pilot balloon, okay? You want to make sure that you blow it up with a 10 cc syringe here. You want to make sure that there's no leaks in it, because can I tell you what's that's super frustrating is you get the tube, you inflate the pilot balloon and it doesn't inflate, and then you have to re-intubate the patient. Pain in the butt. Especially if it was a difficult airway to begin with, because now you're like, well, damn it, now I gotta do this all over again. Securing it is a bit of a kind of trick if you're not using the manufactured ones. Make sure that if you are ever extubating somebody, that you deflate this balloon, because the balloon can and will pull the vocal cords right out of somebody's throat. Not a good look. These are the recommended tube sizes, right? So in adult males, anywhere from 7 to 8 millimeter tubes. Adult females are usually around 7, but you can do about 6.5 to 7.5 is a good size for adult females. Pediatrics. These are things that you're going to want to write down and remember, because they love to ask these questions. Age in years divided by 4 plus 4 for an uncuffed tube. Age in years divided by 4 plus 3.5 for a cuffed tube. Cuffed tubes, I want to say, start around a 4.0 or somewhere around there. So, you want to, make sure younger patients don't need a cuffed tube, like this pilot balloon, in order to keep it in place, because their airway is funnel shaped. So it's much more narrow at the vocal cords, which keeps it in place. It doesn't mean you don't want to make sure that it's secured and in a good spot. A lot of different things that you can do in order to get an advanced airway. The most traditional are your Mac blades, or your Macintosh blades, right? So we talked about this earlier. You just place the tongue, you put the tip of the blade in the vallecula, and you lift up. So when you are going to, versus here where you just take the Miller blade and you put the epiglottis underneath it, you have, I think, a better view, because the epiglottis can fall down and be in the way, so you can't see well. You can also have a video scope, all sorts of other new and exciting things. Bougies are in favor these days, but if you aren't familiar with using a bougie, I end up making a mistake. I personally don't like the idea of a bougie because it's really a blind intubation. You hold the laryngoscope blade or the laryngoscope handle in your left hand, okay? For those of you who are like, but I'm a righty, I get it, but you'll learn, trust me. And rather, you don't want to wrench. Oh, let me stop sharing for a sec. When you're intubating, you want to make sure you have a stiff wrist. Gentlemen, you should be good at this. Stiff wrist. You don't want to crank the wrist back, because the second you do this is the second you start breaking teeth. Okay, so when you're cheersing, okay, so you're holding a handle and you want to go up. Okay, so you're going up. A lot of times you'll take your forearm and you'll maybe rest it on the patient's forehead in order to guide your arm up instead of cranking back. Because again, you don't want to go cranking people's teeth. Cool. Definitely make sure you try out both when you guys get back into lab. Make sure that you actually do try both. I know it's a lot different on a mannequin than it is in a real person, but I learned on the Mac, and then I got in the field and I started using the Miller and liked it a lot more. So make sure you kind of experiment when you have a mannequin to do so, rather than doing it on like a live patient. That's it. Nope. Definitely make sure that you prepare appropriately. You want to have all of your stuff, right? You want to take your time and make sure that you have a stylet, because can I tell you the number of times Jamaica does not have preloaded tubes. You have to put your own stylet in. Can I tell you the number of times that you go to intubate and you don't have a stylet in there? You're like, crap, right? You could do it. It's not going to be the smoothest procedure, but you can make it happen. But if your partner is, ventilating the patient with BLS procedures while you're setting up, you have time. You don't have to rush. They do like to say to put a nasal cannula on patients, because it's kind of passive oxygenation. Make sure that your pilot balloon doesn't have any leaks. Make sure that you keep the tip of the laryngoscope or the tube inside the sterile wrapper for as long as possible. I see some people do some wild things with those. When you are intubating, you need to make sure that you have visualized the vocal cords, right? And then document that you visualize the vocal cords, okay? Because if you say vocal cords are visualized, tube passed through the vocal cords, positive chest rise, positive condensation in the tube, no one's going to, doubt that you did what you were supposed to do. It's just better. It's safer for yourself. A CYA kind of thing. Epiglottis is attached to the tongue at the very base. You should be elevating it either with putting the Mac blade in the vallecula or using the Miller to lift the entire airway. This is the Malampati score. Not that you're going to be really probably doing this. This is what the surgeons do if they have to intubate somebody before they start, before they bring them to the OR. You have the easiest to intubate, which is your class 1, right? You can you have somebody who stands in front of you, opens their mouth, and you can see all the way down their throat. You'll be able to throw a tube down there like a hot dog down a hallway. And then it gets more difficult the less of the airway that you can see. I think it's going to play. Yeah. You can't hear it? It's just a very Indian man talking. You're really not missing anything. I'll send the link out to this, but it's really for the visualization. All right, so this is your Mac blade. You deflect the tongue to the left. Yes, so see that part, right? Hold on. That's your epiglottis right there, okay? So there's vocal cords. See, he's putting a little cricoid pressure on. He's got a great airway. See, he's moving it back and forth. It's creepy. Yeah. So now watch how he goes to pass the tube. Right? So, oh, his big old hand is in the way. Yeah, so one of the tricks that I learned like after the whole like actually learning how to intubate thing was that if you twist instead of coming in straight on with the bevel of the tube up, so like if you don't know what a tube looks like, Google it. It's kind of like an IV where you have a bevel, right? So the bevel of it is traditionally taught to go up. I had it in service once where they said, if you're having a hard time advancing, turn the tube to the side. If you turn it like to the right a little bit, the bevel to the right or the left, usually the right because your hand is in the way with the laryngoscope, it actually can pass through a little bit easier. I don't know the actual like science mechanisms behind that, but supposedly it's super effective as per an anesthesiologist. Yeah, basically same idea. Okay, I don't know if I can get him back in. I'll send him the link. Well, I'll post the link. He should be okay. Another thing is you want to make sure that your laryngeal axis matches, right? You want to make sure you have a good view. This is why, you can take this pillow, like I know they put it under the head, but I think putting it under the shoulders is a little easier because it gives you this elevation. Like, I don't know what the hell pillow this guy's using. This guy looks like he's having some sort of contracture. But, if you put it a little further under the shoulder blades, you will get this angle. You want to make sure that you get a good look at the vocal cords and that you're passing it through. This is the bougie. If you look, there's the tube. Basically, this, as opposed to the stylet, which is very rigid, this is a gum bougie, and it's a little softer, so it doesn't cause any damage. And the way that it's hockey sticked up like that, you're supposed to be able to feel as you hit the tracheal rings, right? You're supposed to like guide it in and go thunk, 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 and then push the tube all the way in. If you do not have this and you do not practice with this on the regular, I don't recommend just deciding to try it one day. This is like a technique that you should be well versed in. And that's like backed by research kind of thing. Like where, a lot of doctors be like, I'm going to try the bougie and then have a difficult time with it. Because now this blue bit is pretty long. It's like 3 feet long. So like you have a lot of stuff to maneuver. It's bad enough that you have the pilot balloon at the end here kind of whipping around when you're trying to get it out of the package. And, this is like a controlled environment thing, personally. Video laryngoscopy, I never enjoyed it in so much as I always had issues with the screen. It's sort of like you go to move up, right? It's sort of like when you're a southpaw playing video games and you go to like use the video, you hit the to move the video and the video game up and it looks down instead. It's sort of the same idea where you're having like a little bit of, if you don't practice with it, you're going to have a hard time. Supposedly it does decrease the time to intubation, but again, that's with a lot of practice. If you don't have one of these where you're traditionally using it on the regular, it's not going to make your life any easier. We do teach naso intubation. We don't teach digital intubation because it's a great way to lose a finger. But yeah, it's there. It's a thing that you should know. Not necessarily how to do it, but that's an option. We do teach you nasotracheal intubation. This is for patients who might have like significant trauma to their mouth where you can't see, but like they definitely don't have any head injury, or trismus, or they might have been. But it's traditionally used in patients who are like awake or more awake. He didn't look like he was the most awake. This is often done with like a light, or like a guide light, so that you can see the light through the cricothyroid membrane. Patients who have like their jaw wired shut or something like that, you can use this for. Not very commonly used.
75 Stratford Avenue.
A lot of different things. This is why we need to make sure that you practice. A lot of different things that can go wrong when you intubate. Majority of the time, it's that you've intubated the esophagus or you've intubated, the right main stem. Both of these are relatively easy to fix. You extubate the esophagus or you pull back on the tube a little bit. Dental trauma happens, but again, you need to make sure that you're using the right technique. You can even see right here. See, he's got a stiff wrist. He's pushing forward. He's not cranking back. Vagal stimulation is a big concern. Okay, this happens a lot more than you'd think. So your vagus nerve goes from the back of your throat to your butt, right, to your anus. So if you are in there trying to pass a tube and you hit the vagus nerve, the patient can start becoming bradycardic, which is why it's super important that you have a patient on a cardiac monitor while you're doing any of these advanced procedures. Okay. Most of the time, if you can have a patient who is intubated and you can also see that they start to become bradycardic. If you kind of move the tube a little bit, like kind of just wiggle it over and release some of the pressure on the nerve, you can actually probably fix a lot of that bradycardia, especially if they weren't bradycardic beforehand. Hypoxia is a concern. The one thing I think is kind of wild is that in the controlled environment of the OR, when you guys do your OR, you're gonna be like, what is going on? They will leave a patient just chilling for like an extended period of time without ventilation after they've like paralyzed them. They're like, no, he's got plenty of oxygen. The problem between a controlled environment with a relatively healthy patient going into the OR versus the emergency EMS realm is that our patients don't often have that level of oxygen when we're about to go intubate them, right? So you need to make sure that you ventilate them appropriately, oxygenate them beforehand, and don't really like putz around while you're trying to tube. One of the kind of rules of thumb is that if you can hold your breath, like you can basically take as much time to intubate a patient as you can to hold your breath. So the second that you start to need to breathe is the second that your patient also probably needs to breathe. Go ahead. Yes. No. It's definitely not. It's definitely not easier with it on. It limits your motion a lot. It pushes that it afterwards, potentially. Yeah, but like while you're trying to intubate, it basically pushes the jaw up. So, that little jaw tray that it kind of sits in, it pushes that jaw up so you don't have as much room to maneuver inside the mouth. Go ahead. Mm-hmm. Yep. So if you look, you can kind of see this guy's, he's holding manual stabilization, as well as this person's helping as well, but they're also doing the cricoid pressure. So you actually have about 3 hands on this guy's airway, on his manual stabilization. You have 1, 2, and this arm. With a little bit of cricoid pressure going on here, which is also, I wouldn't necessarily call it C-spine stabilization, but it's the guy's head's not wiggling back and forth. Does that answer your question? Mm-hmm. Mm-hmm. So if the patient has what we like to call like a really anterior airway, so when you go in and look, the airway's above your line of view. So if you apply the cricoid pressure, it's going to push it down into the line of view of the person who's intubating. It also puts pressure on the esophagus to limit vomit coming up. Yeah. The way that they're doing it right here with like the whole hand is not recommended. It's really kind of more recommended you take like 2 fingers and put it on either side of the trachea and push down, just because you also don't want to smush the trachea that they're trying to put a tube into. So gentle. Gentle is also okay.
7-1 and 7-3. I have the daughter-in-law on the phone.
So, all right. Spinal precautions we just talked about. Well, you can use your own legs to secure a patient's head. Done that before. Kind of fun. Kind of weird. It's like if you're kind of working on your own. You can do a face-to-face. We call it the ice pick. You're kind of taking it like a tomahawk and going into the patient's mouth and like sitting on their lap. One of those advanced maneuvers that you're going to do if the patient's like stuck in a car or something. Yeah, just weird little things that you might see. So here you go. Here's your tomahawk procedure. You can actually see down the airway pretty well, which is pretty crazy. But you see, she's like, grandma's over here sitting in this lady's lap. I don't know. So the pediatric airway we talked about a little bit, right? That it's funnel shaped so that the airway is its most narrow here at the vocal cords, which is why you don't need a cuffed tube. But they have a very large tongue. And when you get into the lab, you're going to see like the differences between the adult laryngoscope and the pediatric laryngoscope. Really much different. But you kind of see like as you get older, the epiglottis starts to change in shape. So it is more recommended to use a Miller blade for a pediatric because the epiglottis is just a little more floppy and wiggly than it is in an adult. It's just got a lot more length to it so that when if you put in the vallecula, it's not going to necessarily go. It's not as stiff. It's not going to go. Here's the saddest picture. Pediatric, you might have to decompress a pediatric's stomach if you do intubate them because they're so small that if you have ventilated them and ended up getting air in their stomach, it's going to really impede chest excursion. If they have baby teeth, you might knock them out, especially if they're loose already. Don't lose that. That kid's going to want it for the tooth fairy. When you are looking at how deep the tube needs to be, another little formula just to keep in the back of your mind, it's the patient's age in years divided by 2 plus 12. So if you have a 4-year-old, it's going to be 14 at the teeth. We talked a lot about this already as well in the documentation section, but you want to make sure that when you confirm your tube that you've seen it pass through the cords. All right, the first thing you want to auscultate is the epigastrum. So like if you feel at the bottom of your chest, right where the ribs end, right in the middle, you're pretty much going to put your stethoscope right there. If you hear gurgling noises, you're most likely in the stomach. So basically you want to listen there first because if you are 100% in the stomach, you don't want to put so much oxygen or so much air in that stomach that you create a geyser. It's just cleaner. And then you want to check mid-axillary, left and right, on the anterior side as well as on the lateral sides. Chest rise is a great indicator that the patient has been successfully intubated. If you only have one side moving and the other side, which is commonly the left side, you're most likely in the right main stem. End tidal is your kind of golden rule. You must have an end tidal waveform in order to confirm that the tube is good, and you want to make sure that you kind of make a note of where the tube is at the teeth. So for example, if you're now transporting this patient down a flight of stairs and you started with 24 at the teeth and then you get down to the ambulance and it's 28 at the teeth and you only have lung sounds on one side, you may have moved that tube deeper. So you might have to pull it back out to 24. Your golden standard, capnography and waveform. So you want to make sure that your number is here, it's calculated, and that you have a waveform. The waveform should be kind of box shaped like this. It should angle up a little bit, and we're going to talk about that more when we do the end tidal lecture, just because that's like a lot of information for you guys. Other things that we have seen is the colometric end tidal, kind of out of favor now because it can be tricked. Basically, it's this little tiny squared thing that you put on the end of the tube, in between the tube and the BVM. And when it's purple, and then if there is carbon dioxide present, it turns yellow. Super simple, but if stomach acid can also change the color of the litmus paper. There's also the bulb syringe esophageal detector. Basically, you take this syringe, you squeeze it, you put it on the end of the tube. If it inflates without an issue, you're in the lungs. If it doesn't, you're in the stomach. Things that we don't really use anymore because we have this magic on the end, on the whatchamacallit, life pack. Little intro to capnography. This is why it's shaped like a little box. You're basically measuring your end tidal. So if you are breathing in, or how much carbon dioxide is coming out. If you're breathing in, right here, as you're breathing in, you're not going to have any carbon dioxide coming out because you're pushing it back into the lungs. Okay, that should make sense. You should have this huge upstroke as a patient exhales because there's carbon dioxide coming out, right? And that levels off after a while, right? Because you're not like blowing really hard and then breathing in really hard. You have like a gentle kind of exhalation normally. And it gives you also an indirect measurement of how well the patient is perfusing, right? So if there's no good blood coming back to the patient's lungs, right? They're septic or they're in a shock state of some one way or the other, or they're in cardiac arrest, you're going to have a very low end tidal number because there's no carbon dioxide making it back to the lungs because of lack of perfusion. It also can give you a good information regarding bronchoconstriction. Let's see if I have a picture. Yes. It's called the shark fin appearance because of it kind of gets a little more pokey instead of being like square because the restrictions in the lungs cause this like kind of just upstroke. And it looks like a shark. If you suddenly lose your waveform, right? Maybe the tube is dislodged, maybe it's obstructed, maybe the patient has suddenly gone into cardiac arrest, as opposed to here where your end tidal suddenly goes up. It's a very strong possibility that the patient has a return of spontaneous circulation. Right, so you have a number of different things. If you have like really fast, small boxes, the patient is hyperventilating. Like big, long boxes, the patient's hypoventilating. A number of things. It's really cool how much information you can get from capnography. That's like an entire class all to itself. Pulse oximetry is useful, but not 100%. We kind of already talked about that, right? So, the patients who might have a low red blood cell count might still have an SpO2 of 100% because all of their 5 blood cells are 100%, bound with oxygen, but they don't have enough red blood cells to be effective in general. Nail polish is also an issue. Patient has cold extremities or a low perfusion, like very hypotensive. You might not have the most effective. We talked about the king tube a couple times already. That's here. So you can kind of see where this won't necessarily be as effective if you have somebody who has a lot of blood, right, in their airway, because it's just going to kind of pool and it can still kind of seep through and around because there's no guarantee that this is going to end up, like this ends up in the esophagus. It doesn't end up in the airway. So any pooling blood can still end up into the trachea. The LMA is the laryngomask airway. It's supposed to kind of fit into the esophagus so that it blocks the esophagus and only allows air to go into the trachea. Again, not a definitive airway. Any sort of blood or vomitus or something that is already pre-existing can still end up in the trachea. Thoughts, questions, concerns? Cool. We talked about this already, so we're just going to review really quick. Drug-assisted intubation, we commonly use etomidate and midazolam here in the city. Fentanyl is a possibility. I don't believe that that's in protocols. However, ketamine is fantastic when you want to make them think that they are a banana tripping acid somewhere. A lot of the times we use it to help reduce their anxiety and produce amnesia. And it also helps in reducing the gag reflex and from the patient from chomping down on your laryngoscope blade as you try to intubate them. Again, we talked about a lot of this stuff. You want to use a lot of these medications to create paralysis so that you have easy access to an airway, because people don't commonly enjoy having people in their mouths, as known by dentists everywhere. So yeah, a lot of different things that you might have to. If your patient's awake and you need to intubate them, this is what you're going to need to use. You're going to need to use what medications are available for you. Etomidate is here. It's 0.3 milligrams per kilogram. Okay, commonly up to a 20 milligram. I do believe that you have a max of 40 in protocol, and then you combine that with midazolam. Again, we talked about the depolarizing agents, right? This is going to cause fasciculations and muscular contractions. So it might not be super effective because those muscular contractions can also end up in the jaw, which just means that you have a clamped jaw, which doesn't help your life at all when you're trying to secure an airway. The non-depolarizing agents block acetylcholine at the neuromuscular junction without the fasciculations that's caused, right? So it's just causing an extreme muscle stimulation so that flaccid paralysis occurs. You need to make sure that you have a solid plan before you intubate, no matter what, right? Even if the patient is in cardiac arrest, you still need to make sure that you have a plan, that you've gotten yourself in the correct position, you have space. Can you move the patient? Then move the patient to make yourself some space for yourself, right? Get them positioned appropriately so that their airway is aligned so that you'll have an easy time. Make sure that the patient's being pre-oxygenated. If you have to put a nasal cannula on them, then do so. If you have extra hands, take advantage of them. Make sure, for RSI, drug-assisted medication or drug-facilitated intubation, no. So like that's what they do in the city, it's drug-facilitated intubation when they use the etomidate and the midazolam. You don't have to, there's no special, you just have to call and get orders. So it's, you just call and say, hey, patient's hypoxic, they're not getting any better with oxygen and they're becoming combative, I just want to sedate to intubate. And they're like, okay, gonna give 40 of etomidate and 5 of midazolam. They go, can I get another 5 in case they start waking up? And they're gonna go, sure, 5 on standby. And then you push the medications and you do what you have to do. It is super important that you don't push the medications before you are 100% set up and ready to go, because they're very short acting. And good luck getting a secondary dose. Yeah. I know it says rapid sequence intubation, but any sort of drug facilitated intubation, you want to make sure that you're going to be successful, right? This is why you set yourself up appropriately before you even start. If you don't think that you're going to be able to ventilate the patient if you sedate them, then don't take their respiratory drive away. Just get to the hospital faster. Let them, do what they have to do. If you have any concerns that there's going to be a lack of success, not necessarily the best time to try it out. We're going to briefly discuss these because they are not within our protocols. They are national registration protocols. However, you just review this if you take the national registry exam, because this is going to be the last time you're really going to see it. The needle cricothyroid, or thyroidotomy, you take a 14 gauge needle and you put it in that cricothyroid membrane that we all had you feel before, okay? You're going to attach that to a 10 cc syringe to check for bubbles. This is commonly used if you have a patient with a foreign body airway obstruction that you cannot remove or you cannot push forward with intubation techniques. But I want you to think about the size of a 14 gauge needle, which is about the size of a coffee stirrer, and breathing through that. It's effective for about 5 minutes or so before the carbon dioxide becomes too much, okay? Because you can't, it's just too small of an opening to exhale effectively, okay? But if you do have a patient who is, completely obstructed, this might be a good option in a place that allows you to do so. Mm-hmm. Mm-hmm. Yeah. You mean like, hold on, like a surgical cricothyrotomy? Um, no, we are not allowed to do this either. This is not in our protocol in this part of New York State. Yep, no, you're not. The needle decompression is the coolest thing you're allowed to do. And it's also one of the most rare things that you're going to do. But yeah, so this is, remember I was talking about, you want to make sure that you're doing the incision in the correct direction. So the tension lines run this way. So if you cut this way across the cricothyroid area, the skin's just going to peel open like a Pez dispenser. So you have to cut it this way and then do it. So you cut it vertically and then do a horizontal incision on the cricothyroid membrane. Again, not something that you're going to be seeing in the field unless you move to Montana or something. And if you do, please let me know. But yeah, so this is basically, again, you have severe facial injuries, like, you know, that guy, you remember the video, the guy who jumps off the dock and cracks his head open, literally like in half, like back in the day, a couple years old. This guy would probably have benefited from a surgical cricothyrotomy. Any sort of severe anaphylaxis can be used for, but again, not really in our protocol, not something that you're really going to see, period. Hemorrhage is probably one of the biggest ones. There's a possibility of creating a false lumen. Basically, you put this little guy in there, but you don't get it into the trachea. You just kind of put it into the skin of the neck and cause all sorts of other issues. This guy's using a bougie to make sure that he's in the correct location. Small children, you're not going to use this because you can't get really good landmarks, as well as anybody who is like morbidly obese and you cannot identify anatomic landmarks. Just a side note. And that's it. That's our airway lecture. Questions? No? We're all good? Want to do a little... Go ahead. Mm-hmm. Yes. Yeah, so if your patient is not as unconscious as you think they are, they can bite down and you can just be injured. Because you're sticking fingers into somebody's mouth to hold the epiglottis up and guide the tube in between your fingers into their airway. 10 out of 10 not recommended. All right. Do you want to go over the quiz, the math from the quiz from this last week? All right, cool. Let me just set it up. Okay. Nope, not that one. Okay, the first question. We can just make some space on my desk really quick. Okay. You need to administer 5 milligrams per kilogram of a drug to a 220-pound patient. The drug comes in a 10% solution. How many milliliters will you administer? Okay. First thing. What do we need to know?
Someone repeat?
Perfect. So 220
was concerned about his medical condition, correct?
is how many? How many kilograms?
He just said he was
Perfect.
passed out on the bench. I'll start off now.
Okay, so now we have our kilograms. And how much do we want to administer? 5 milligrams per kilogram. Cool. So 500 milligrams, right? So this is our desired dose, right? Okay. Now, our medication comes in a 10% solution. So it is how many grams or milligrams? There you go. So that's 10 grams in 100 milliliters. Yep, there we go. So that's derp. Right? Get rid of your terminal. So you have 100 milligrams per milliliter. That's your dose on hand. So how many milliliters do you need to give to get 500 milligrams? Yep. So remember the gram percentage that we talked about? So when you have a percent solution, that is how many grams, your percentage is how many grams are in 100 milliliters. So I think this comes up again, hold on. In the dextrose question, right? So we'll do it again. So you have your dextrose solution is 50% dextrose solution, right? So that means you have 50 grams in 100 milliliters. Correct. Yes. Yes, unless, little asterisk, unless you're dealing with an epi, 1 to 1,000 or 1 to 10,000. Because that's when you use it. It's 1 gram, like epi 1 to 1,000 is 1 gram in 1,000 milliliters. Epi 1 to 10,000 is 1 gram in 10,000 milliliters. Yes, if it has a percentage, it's out of 100 milliliters. All right, so let's finish up with this question. So this becomes 50,000 milligrams over 100 ml. Okay. So you have 500 dose on hand is 500 milligrams per ml. Okay. Now, the question asks, you are administering 50 milliliters. Okay. So, if every milliliter has 500 milligrams in it, and now you're administering 50, five times 0, 5 times 5 is 25. And this is milligrams, right? But they want to know how many grams. So, exactly. So you're going to take this decimal point that exists right here. You're going to move it over 3. 1, 2, 3. So it's 25 grams. Yes, you can. Perfect. All right. Okay. Mm-hmm. Oh. Mm-hmm. Mm-hmm. Because I was doing it because we had questions about the gram percentage. Yeah, so if you wanted to do like a cross multiplication, so it's 50 grams over 100 mLs, right? And you want to know how many grams you get if you are giving 50 mLs, right? 50 times 50 is 2,500. 100 times x is 100x. You want to get the x by itself, so you divide both sides by 100. Divide by 100. Or as Joni said, like if you look at, you have 50 grams in 100 milliliters, and you're only giving half, that means you're dividing 100 by 2, which means you're going to divide the 50 by 2, which is 25. So it's like 3 different ways you could do this problem. Get it? We're good? Okay. All right. You need to administer 10 milligrams per minute of a drug to a 198-pound patient. You put 1 gram in 250, and you're using a 60-drop set. What information do you not need right here? The weight, right? So no one cares. Cool. What is your desired dose? "10 milligrams a minute." What's your dose on hand? Okay. Can you do grams and milligrams together? How much is perfect? So let's simplify. Get rid of your terminal zeros. How many times does 25 go into 100? 4 quarters. Beautiful. 4 milligrams per milliliter. All right. Correct. Yep. Nope. Because it's essentially the same number, right? You're just changing the units. So if 1 gram equals 1,000 milligrams, they're equivalent, right? So you're just changing it so that it makes it easier to work with the numbers. Okay. All right. So now which ¿cómo se dice? Which formula are we using? Which is what? What am I putting in? Perfect. So, desired dose is 10 over 4 times 60 divided by 1. Or divide by 1. 10 times 60? Divided by 4. 4 goes into 6. 4 goes into 20. 4 goes into 0. There you go. So your drip rate is 150. Yes. Exactly. Exactly. All right. We got this? You have a burn patient needs 2 liters of lactated ringers over the next 5 hours for fluid replacement. Using a 15 drop set, what is your drip rate? What are we using? Which formula? Times your drip rate, drip set, right? So, are we going to be using liters or milliliters? Yep. Are we using hours or minutes? Minutes. So 60 minutes in an hour. I'll get there eventually. 300. Good. Times your 15 drop set. So first things first, let's simplify. So now you have 20 times 15. All right, 5 times 0 is 0, 5 times 2 is 10. 1 times 0 is 0, 1 times 2 is 2. Perfect. 300 divided by 3. There you go. I'm telling you, it really is. It's just a matter of slowing yourself down and pulling out the important parts of the question. Because you're all getting it. Like, you know, you're following along without any issues. I think it's just you see it and go, oh crap, it's math. And then, like, start panicking. Just deep breaths and you'll be good. All right. Let's pick out the important stuff. You need to administer 0.5 milligrams of a drug to a patient. The drug comes in a 1 ml syringe that has 1 milligram of the drug. How many milliliters are you going to administer? Half a milliliter. Good. So you have 1 milligram in 1 ml, and you want to give 0.5 milligrams, and you don't know how many milliliters you want to give, right? So your milligrams, when you're cross multiplying, your milligrams and your milliliters need to be on the same side. Okay, so 1x, that's a terrible x, equals 0.5 milligram, divide 0.5 milligram per milliliter by 1 ml, or 1 milligram, that's 0.5. Good? All right, we did that one. You have to administer 150 milligrams of a drug to your patient over 20 minutes. Okay. You put that 150 milligrams in a 100 milliliter bag of normal saline. Using a mini drip, what is your drip rate? So what formula are we using? No. Exactly. So it's always volume over time. If you have anything that's not like mics per kg per minute, right? So if you're not working in like a minute, if it's 20 minutes, 10 minutes, an hour, you're going to be using your volume over time. Okay? And this is your distractor right here, is that you're putting 150 milligrams in. Does it matter if I say, oh, I'm going to put the 500 milligrams in? Does it matter if I'm still giving that patient all of this milligrammage over a certain amount of time? No, because I'm mixing it in here. I'm mixing it in this bag. So this patient is getting all of this in this time because it's going to contain all of the medication that I want to give. So our volume is 100. We're dividing by 20 minutes. What is our mini drip? How many drips are in a mini drip? Perfect. 60. So let's simplify. 10 divided by 2. 5, right? Okay. But here, let's go this way first before I don't want to confuse anybody. 600 divided by 2. There you go. Good? Mm-hmm. Knowing which formula. Okay, we can fix that. That's easy enough. So here, work this one out with me. Yep. All right, so let's pick out the important information for this one. Mm-hmm. Yeah, I agree. So there is a rule that if you add more than 10% of the volume, so like if you have a 100 milliliter bag and you put more than 10 milliliters of a medication in, you have to calculate that additional volume into it, because otherwise you're not going to give the full amount. So yes, you are correct from the concept of that should be calculated as 140 milliliters. I don't know why he decided to use such a large amount of medication. I think it was trying to make you do like the math of, you have, 20 milliliters of vials, so let's work it through to get, disregarding the fact that second part of the math is wrong. We know we're going to use the volume over time, but we need to figure out our dose on hand. Wait, no, this isn't. Just kidding. This is the desired dose on hand. No, sorry. Small stroke. I got a little agitated about the other thing. All right. So, your desired dose is 5 mgs a minute. and you have to find out what your dose on hand is. So your dose on hand is you have two 20 milliliter vials, right? So let's figure out how many milligrams are in one vial. So you have 20 milliliters, and there's 5 milligrams per milliliter. 100 milligrams. But you're putting two vials. Okay. So now you're putting 200 milligrams in a 100 milliliter bag. So your dose on hand is 2 mgs per milliliter. Five times 60. Okay. 300. Okay. Divided by 2, y'all give me anxiety, is 150. So, yeah, you did 200 in 140, which is just like much more math. If you ever start getting like something really funky like this, you're probably thinking too hard. Because like a lot of the time, try to make the math relatively simple. Yeah, pretty much. Yeah. All right. You need to give a 176-pound patient 10 mics per kg per min of a drug. You put 200 and 250, and you're using a 60 drop set. Which formula are we using? Good. Times 60 over 1. Okay, cool. Easiest thing we should do first. Okay, so how many kilos is 176 pounds? Well, we should memorize this one. 88. Just 80. And you want to give them 10 mics per kg per minute, like my squiggles. So that's 800 mics a minute. It's 80. It's 80. 80. So this here is your desired dose. Now, 200 milligrams in a 250 milliliters bag. This should look familiar. What's my concentration without math? Oh, y'all didn't memorize. $800. This is your standard dopamine. Remember that. 1, 2, 3, 4, 5, 25. 800. Okay, so we plug in our numbers because this is our dose on hand. So let's plug in our numbers. Our desired dose is 800. Mike, yep, this is mics per milliliter. So our desired dose is 800 micrograms per minute. As I have a small stroke. Our dose on hand is 800 micrograms per milliliter. We are going to multiply that by 60 GGGs a minute. Mics cancel out. Minutes cancel out. Because I know some people are probably like, what are we doing with this? 800 divided by 800? 1 times 60? This is milliliters, sorry. I did that wrong. Good? I think half of you have died. Yeah. Yeah. That's like a lot of extra math. It's very mean to yourself, Johnny. Okay. Let's pick out the important stuff. You need to administer 70 milligrams of a drug to a 154-pound patient. Your drug comes in 10 mLs syringe that has 100 milligrams of the drug. How many mLs are you administering? What's not important? Weight, right? So don't care. So your desired dose is 70 milligrams. Your dose on hand equals 100 milligrams in 10 mLs. Simplify. So you have 10 milligrams per ml. How many milliliters? 7. Another way to do it. You have 100 milligrams in 10 mLs. Cross multiply, you want 70 milligrams. Now you need to figure out how many mLs. So you have 100x equals 700. Divide. Yay, math. All right, last one. Okay, so this one you could have answered using basic knowledge or using your gram percent. Okay, your epi 1 to 1000 in your little ampule that you get it in, it's a 1 milligram and a 1 ml ampule. So if you knew that, you could figure this out pretty easy, right? Because it's a 1 for 1. So it would have been 0.3 milliliters. However, let's do it the long way. So we talked about how the gram percent, right? If is a percentage, it'd be 1%, it would be 1 gram in 100 milliliters. This gives you a different ratio. Okay, so this is 1 gram in 1,000 milliliters. Okay, so 1,000 milligrams in 1,000 milliliters equals 1 milligram per milliliter. So if I have 1 milligram per milliliter and I cross multiply for my 0.3 milligrams, that makes sense? You see that? How it should just be 0.3. 1x equals 0.3 milligram per milliliter. Divide that by 1, 0.3 milliliters. We good? Hello. We're all still here. We all survived. Feel a little bit better with math. No. No. All right. I will send you some questions and we'll go over them next week, but I'll let you practice on them. I don't know if there's math on this quiz for today, but I'll send you questions in your email so you can practice. No, just practice. You don't have to do them. I'll go over them next week, but you know, if you want to actually figure out math and feel comfortable, I highly recommend doing them. Yeah. Sure. All right, guys. Any other thoughts, questions, or concerns? Can someone please get Rob out of witness protection? Oh, good. I'm glad it's clicking. It's getting there. Click, click. It's not just the alternator. All right, guys. I will post this to let you know when it's posted. If you have any other questions, please let me know. Throw it in the group, and I'll send out those practice questions for you as well. All right. Please make sure you're keeping up with your workbook because this is a relatively short module. So make sure you get those done and have a lovely day. Probably you. You're welcome. Have a great day, guys. Bye. Bye.